Today we're going to talk about the art of minimally invasive spine surgery, of the lumbar spine in particular. We've spoken in other segments about indications for surgery, and this time we're going to be talking about the actual surgical techniques. So what minimally invasive surgery means is that the entry into the spine is minimized, made smaller, and the amount of trauma to surrounding tissues of the spine is minimized. So let's first look at a model of the spine to understand a little bit about what we're talking about. Here we have just the skeleton of the spine. Of course, it's held together by ligaments, muscles, and tendons. So we have the muscles of the back coming across and attaching to the spinous processes and lamina of the spine. The spinous processes you can feel when you run your hand up and down your spine. And the lamina or roof of the spine cover the spinal canal that the nerves run through as a group called the cauda equina in the lower spine. The spinal cord ends at the upper part of the lumbar spine. The nerves come out or come in to go to the legs through this opening called the foramen between the joint and the disc. The paired joints are called the facet joints, and they're what allow for movement of the spine. The discs are the cushions in between the vertebrae, which are the building blocks of the spine, and these cushions are compressible and re-expandable. They keep bone from rubbing against bone. So there are different problems related to the spine, both genetic, related to growth abnormalities such as scoliosis, where there's a twisting of the spine, or to damage to the spine from trauma, such as accidents that can result in fractures of the vertebrae, including the joints, that can cause compression of the nerves, and from tumors that can grow in the bone, destroying the bone, and from the most common problem, which are degenerative changes of the spine over time, wear and tear. All of these can result in compression of the nerves that cause neurologic injury and loss of function, such as weakness in the legs, numbness in the legs, and even bowel and bladder problems. It can also result in instability of the spine, where there is excess movement of the spine. And so we have to have techniques in which we enter the spine to resolve these problems. With the standard techniques, the muscles have to be divided off of the spine. The muscles are pulled over. The tendons have to be divided that attach the muscles to the bone. And in holding those muscles open to expose the areas we want to operate on, it causes a lot of swelling and injury to those muscles. And even when they recover after surgery, there may be scarring within those muscles. The muscles can be more sensitive. The muscles can be more likely to spasm. So there can be some long-term consequences from the standard procedure. Additionally, to gain access into the spine, the lamina are removed and the spinous processes are removed. So a large portion of this bone may be removed to gain entrance into the spine, and sometimes even the joints or parts of the joints have to be removed. When parts of the joints are removed, there can be instability of the spine because nothing is really holding one vertebrae together to the next. So the standard approach to repair the spine is actually quite a destructive procedure as well. So minimally invasive procedures have been developed that limit the amount of this destruction. What that means is that we can gain entry into the spine through smaller incisions and through separating out the fibers of the muscle rather than taking the muscles directly off of the bone and cutting the tendons. When we separate muscle fibers to gain access, the muscle fibers can go back into place once the surgery has been completed. We're able then to make smaller openings into the spine, removing much less bone, and certainly we can do it from one side most often. We don't have to remove the bone on both sides of the spine, so it leaves a lot of the spine intact. Through that approach, we're able to both remove spurs that can form along the margins of the joint or the margins of the disc. We can remove thickened ligaments that grow around damaged joints and arthritic joints. And we can make sure that the nerves are freed with problems such as stenosis, where there is a narrowing of the entire spinal canal, so the nerves get scrunched as they're trying to get through that very narrowed canal. Stenosis is a very common problem among people who are in their 7th and 8th decades of life. So what are the various techniques that we utilize? Often nowadays, when there is damage to the joints as well from instability, or when there's a fracture, we have to stabilize the spine, and we have to do that by putting in hardware into the spine. We want those segments that are damaged to fuse. In order to get them to fuse, we have to put an internal brace in. When you have a fracture of an arm or a leg, you generally wear a cast because you want to immobilize that bone to allow it to heal. Well, it's the same for internal bone when you want it to heal and fuse. So there are different methods that we can now use to fuse the spine. The most common system is to put in what are called pedicle screws. And so these pedicle screws go into the vertebrae. This component of the spine is called the pedicle. We drill into the pedicle. That bone, that screw then is through the bone with just the head of the screw outside the bone. We put 2 of those in and then a rod in between, tighten down the caps on these screws. That locks the rod in place, and so there's no movement possible at that segment. When you do standard spine surgery, the muscles have to be removed, and then through direct visualization you can put these screws in. You have to be very precise to make sure that the screws don't go into the opening where the nerve comes out, because that can compress the nerve. Even with great care, that can happen sometimes, because these pedicles are different sizes in different people. And as we do it, even under direct visualization, sometimes the outside of the pedicle can be breached. Now, with minimally invasive procedures, we're able to put these screws in through small openings in the skin directly into those pedicles without having to directly visualize them. And we even have now computer guidance systems where we're able to take computerized tomography images of the spine during surgery, feed that into a computer, and then, looking at the computer image, drive these screws into the pedicles. It makes it extremely safe, and it means that you have to do very little tissue damage to get those screws in. Additionally, we often have to replace the disc. We have to remove the disc and put in a spacer in between. There are now methods in which we can get into the disc, making only a very small opening in the disc. With the more standard approach, where we put in a structure somewhat like this, we have to make a pretty wide opening into the disc in order to insert this. But there are now ways in which we can make a very small opening into the disc, clean it out, and then put in a device. In fact, this can all be done percutaneously, meaning just through small incisions in the skin. One of the systems that I like to use is this system called an Optimesh device. It goes in essentially like a sock at the end of a tube, and we can put that in through a small tube, through a small opening in the disc, and then we expand that sock once it's in the disc by putting bone paste into that device until it hardens as it expands the disc space and keeps that disc space open, allowing bone to grow through it. And then we can put the pedicle screws in percutaneously, and you have a fusion without having to take down any muscle, without having to take down any tendon, without having to do any destructive approaches to the spine. Additionally, there are in fact multiple minimal access techniques. One of the ones that I like is through a very small incision, again, taking down only a very small amount of muscles over the spinous processes. Rather than having to put screws into the pedicles, we can put this clamp between the spinous processes that clamps down and then prevents the bone from moving by holding one spinous process to the other. We put bone in the opening there, that bone grows and then fuses to form a fusion bridge across these spinous processes. We've discussed several of the approaches to minimally invasive spine surgery of the lumbar spine. There are additional techniques, but there are certainly advantages to minimally invasive spine surgery. And in fact, this is the way of the future. It allows for quicker recovery. In fact, patients who have percutaneous lumbar fusions often can go home the same day. And often now, with minimally invasive approaches, if patients aren't going home the same day, they're going home within 1 to 2 days of the surgery. They're not staying in the hospital a week or more, as had occurred in the past with some of the more involved standard approaches. Recovery not only is quicker, but the long-term effects of surgery are diminished. There's less back pain, there's less of a problem related to the surgery itself over time. I'm Dr. Ezriel Kornel. Thanks for tuning in, and I hope that you listen to other segments of our educational videos about the spine.